All right, everybody. So I know I talk a lot about kind of intra-op stuff. So I thought, why don't I flip the script for this Thursday Thrive in 5 and talk about what happens like when you try to wrap everything up in a nice tight little bow at the end and like they go to PACU and they're still kind of a hot mess. So I just want to talk a little bit about PACU management. Let me share my screen. There it is. It's like staring at me. Okay, beautiful. Okay. So we're going to run through a quick scenario and just give you kind of a little bit of things I want you guys to kind of think about as far as patient goes and management in PACU. So something similar like this happened, but you have a 97-year-old female. You can see the history there. Had an XLAP done, they lysed some adhesions and did a bowel resection. So during the case, there's about 250 of EBL. See, she got quite a bit of crystalloid and some albumin for some hypotension that was happening. Patient was on a cardizem drip also preoperatively for kind of new onset AFib with RVR. Looks like they had given some esmolol for some rate control that seemed to help. They stopped the cardizem drip, and then they also were given some neo, and you can see the fluids and the albumin for the hypotension. So this is what happened intra-op. So then you come to the OR or you come to PACU, and this is what you see. So this patient was extubated. So you extubated, you felt, you reversed, they were fine. You pulled that tube out. They start waking up more, and then you've got like an AFib disaster at about 160s on the monitor. That's your blood pressure. This patient does have an A-line, so you can at least like verify that blood pressure is probably true. You can cycle a cuff just to make sure, but probably true. And then they're 97% on 3 liters nasal cannula. Okay. So what do you do? What do you start doing? How do you prioritize? What are you thinking? What are you thinking about? So first things, all the things you're doing your kind of your survey, right? So this patient was recently extubated, right? So the first thing I'm going to do is obviously those vitals like suck. We need to fix them, but I'm also going to do a really quick look because if they were super hypotensive intra-op, I'm also worried about their mentation. I'm worried about ischemia. I'm worried about their brain. So I'm going to do a quick, are you with me? Are you with me? Can you squeeze my hands, like a quick little mini neuro check and just kind of see first of all, do we need to escalate that airway? Like, do we need to start maybe increasing FiO2, bag mass ventilating? Am I worried about a brain issue as well, along with everything else? That's kind of the first thing I would do as well. And plus, are they fully reversed too? So it really has anything to do with the vitals, but that's kind of like that first initial survey coming out. You're seeing some funky stuff. I'm just looking like, okay, removing extremities. How is our breathing? Are they shallow? Are they following commands? Whatever. And then obviously something you want to do is think about their fluid status. I would probably, it looks like this patient got quite a bit of fluids intra-op, but you can still be probably dripping some in. You might want to be thinking about, volume, etc. So just kind of like that quick, just little glance that we just do in like 2 seconds to also see, because remember, they are coming out of the OR. So yes, our heart rate is super high. That could 100% be explaining why the blood pressure is also low. However, they also just came out of surgery. So are we having some type of hemorrhage? Are they still hypovolemic? So you're kind of looking at all of those things and trying to piece them together, right? And obviously worried about domain ischemia. They could be throwing a clot. You're worried about your low cardiac output, etc. Okay. So heart rate and blood pressure. So how are we going to treat that? Usually over about treating AFib, which is a tachyarrhythmia, usually from, increased automaticity somewhere, some type of triggered activity somewhere in the heart, or mostly it's like a re-entry, right? There's some type of re-entry pathway that's going on, creating that AFib. And this is new onset for them. But once again, you're also thinking like, okay, is there some sepsis going on? Is there hemorrhaging, right? You're thinking of all the things. So anyways, how do we kind of treat AFib acutely? So anytime you're like 150s, 160s, you do obviously want to think about potentially cardioverting, especially with a blood pressure like that. This patient initially was getting cardizem. So cardizem would kind of be my first choice, calcium channel blocker. They were getting it before. I would actually probably give this patient a couple boluses and then restart the drip slowly. and kind of see where they are at. Also think about maybe some amiodarone. I believe this patient did get some amiodarone like later on in the unit, but you can also think about that. However, with amio, I'd be really concerned about like hypotension, right? So just something to think about like that. I'd be worried about that maybe exacerbating that hypotension because you want to fix that. Esmolol. So the thing is, you don't want to get too crazy mixing stuff. And we all tend to do this when we start out because you want to like fix all the little things. So esmolol is something to think about. However, the patient did get esmolol in the operating rooms, you know, and esmolol it's a metabolized by esterases. It is, you know, usually kind of quick in, quick out. However, I would be careful about loading up too many things because then you could also get some cardiac depression, right? More with mixing. And then you could really, you know, your cardiac output's already going to be down. You don't want to depress that heart anymore. So just caution you to kind of think about before you try to throw the kitchen sink, try one thing and give it a little bit of time to work. And trust me, I have no patience. So I get it. It's kind of hard. So something to think about there. Other things, digoxin potentially, but dig is not really for acute like this situations. You could also think about some magnesium, but once again, for a fresh surgical patient, I'd be worried about the hypotension, the breathing, things like that. So I don't think I would go to magnesium for this particular patient. And then I did mention like cardiovert, obviously, you know, symptomatic greater than 160s or so is definitely something you want to think about. Now, as far as the blood pressure goes, that's clearly got to get fixed. So my choice would be phenylephrine, that alpha-1 vasoconstrictor, because you're going to get a nice bump in your SV and your cardiac output, but it's also going to drop that heart rate down as well because you get a reflex brady with that. So it's not going to necessarily treat it and fix it, but it will kind of help your cause. So I would probably, you know, first try to see if we could get a handle on this. Get this heart rate down a little bit, but this patient obviously needs a little bit of neo. You can also be gently dripping in some more fluids. You can put their head down as well if they'll tolerate that. And then you might want to even at that point start to think about maybe I would probably choose some Levophed as getting a little bit of Levophed on board. Okay. And then obviously you have your A-line in. I would draw some labs. Let's look at some electrolytes. Let's pull off an H&H. Let's kind of see where our fluid shifting is happening. What's going on? Is there anything else going on? See how they respond to your interventions. And then for this patient, I'd probably think about dropping a central line in because I guarantee you the ICU is probably going to call you for one later. All right. So I hope that was kind of helpful, but just want to give you guys some pearls of kind of things to think about is when, you know, you don't always tie these patients up with a perfect little bow when they come out, and you have to be able to do some type of management and write orders and think on your feet, especially if you work at places where there's not really intensivists or, you know, people like cardio that you can just call that's like right there to help you out. So I hope this was helpful. If you have any questions, please let me know, and happy Thriving Thursday. I'll see you guys soon.